Now, contraindication. We will speak about few of the contraindications. Remember, these all contraindications are relative contraindications. These are not absolute contraindications, depending upon the severity of the disease. First contraindication of laparoscopy is severe COPD and cardiac disease. Chronic obstructive pulmonary diseases are like bronchiectasis, bronchial asthma, tuberculosis, asbestosis. These all severe chronic obstructive pulmonary diseases are the contraindication for doing laparoscopy. And severe cardiac disease like the CABG, cardiac bypass, stent application, ASD, VSD, severe myocarditis, these all are the contraindication for laparoscopy. Actually, these are not the contraindication for laparoscopy, these are contraindication of pneumoperitoneum, because the CO2 which we fed into the abdomen to distend the abdomen to make a room to perform surgery, it has 4 major drawbacks and 15 minor problems. So, I will discuss here the 4 major problems, 15 I will discuss later. The 4 major problem is, first problem is decrease in the venous return. When we put the carbon dioxide inside the abdomen, it is pressing the vena cava down. It is not only lifting the abdomen up, it is pressing the vena cava down, and due to the pressure over the vena cava, venous return is decreased. In the Johns Hopkins Hospital, they have done one study that in the large animal, they did one study in which they put the CO2 at different pressure. In the first group of animal, they put 6 millimeter of mercury pressure. In the chimpanzee of the normal age of normal weight of the human 70 kg, they put 6 millimeter of mercury in first group of chimpanzee, the insufflating pressure, and they observe the vital parameters BP, pulse, respiration and how the animal behave. With 6 millimeter, animal was happy, sleeping, eating, drinking and doing all the work. They have not noticed also that something is there. In the other group, it was 12. At 12 millimeter of mercury pressure, there was 20% reduction in the venous return. Why in the 6 millimeter of mercury pressure nothing happens? Because vena cava pressure is 6. So, this 6 was compensated by the 6 of the vena cava, and there was no decrease in the venous return, there was no decrease in the cardiac output. In the other group where it was 12 millimeter of mercury pressure, the vena cava was pressed and cardiac output was also considerably 20% decrease in the cardiac output was observed. In the third group of the patient, it was 18. At 18 millimeter of mercury pressure, there was 40% reduction in the venous return, and within few hours the patient was, the animal was unconscious. So, ideally more than 12 or 15 is not recommended to do in the laparoscopy, and even 12, suppose patient is already having the hidden ischemia which was not found during the surgery, patient is 60-year-old, you do not know that patient has some cardiac disease, and you will do the laparoscopy, and suppose there was decrease in the venous return, that will result into decrease in the cardiac output, and then patient cardiac perfusion is decreased, and this ischemia is reflected, and there is an infarction, patient may die on the table due to heart attack, and we do not know. So, that is why wherever you have the little doubt about the cardiac status, you should get one stress echo done, stress echo, not a simple echo. Simple echo may not give you the problem reflected out. So, stress echo done, get a cardiac clearance and then do the surgery. Normal patient can tolerate, but patient who is already cardiac patient, they cannot tolerate decrease in the cardiac output. And even the COPD, suppose the patient has a severe tuberculosis and the patient was just tolerating by the respiratory reserve, and when you will do this laparoscopy, the decrease in the venous return, decrease in the cardiac output which was compensated by the respiratory rate, and now the respiration is already compromised, it will create the acute respiratory distress syndrome also. So, this is the first problem of laparoscopy, that is decrease in venous return. Second problem is decrease in minute volume and tidal volume. At 6 millimeter of mercury pressure, nothing happens, but at 12 millimeter of mercury pressure, there is a 50 ml reduction in the tidal volume. Normal tidal volume is 500 ml. Normally, with each respiration, a normal adult man is inhaling 500 ml of the air inside and expelling it out. But when we create pneumoperitoneum at 12 millimeter of mercury pressure, it is not only lifting the abdominal wall, it is pressing the diaphragm also up. And due to the pressure over the diaphragm, the lung cannot fully expand. And if lung cannot fully expand, there is a 50 ml reduction into the minute volume, tidal volume, and that tidal volume will ultimately is decreasing the minute volume also. Now, at 18 millimeter of mercury pressure, there is 150 ml reduction in the tidal volume. So, if you will see from 12 to 18, the pressure was increased only 1.5 time more, but tidal volume was decreased 3 times more. 50 was at 12 and 150 was reduction in the 18. And now, suppose the patient was having already bronchial asthma, tuberculosis, and he was working with the reserves of the respiratory system. That decrease in the tidal volume will immediately precipitate into the respiratory failure and patient may die. So, this is the second problem, that is the tidal volume is decreased. Now, to compensate this tidal volume, sometime our anesthetists do the wrong method. If they see that in the Boyle's apparatus, their ventilator is not taking 500 ml, it is taking only 350, then they increase the pressure. So, now the ventilator will start giving more pressure to expand the lung. So, from here our pressure, our CO2 is pushing the diaphragm, and from the ventilator the anesthetist is pushing the diaphragm and the lung cannot expand fully. So, there is a alveolar rupture, rate of respiration. Yes. So, he should not increase the volume. If the tidal volume decrease, he should increase the rate of ventilation. So, if rate of ventilation was 12, he should increase it to 18, that is 1.5 times more. Or if the patient is pregnant, or if the patient has any other COPD, it should be double, that is 24 faster, so that the gas exchange will be faster, and if he will not do that, there is a problem. So, sometime once the alveolar get ruptured and a lot of pulmonary edema, pulmonary congestion develop, at the end of the surgery you will see that your patient is not reversing, patient is anesthetized. Anesthetist is trying to make the patient awake, but patient is not awaking, and he is doing a lot of suction, and if froth is coming from the mouth, which anesthetist is busy doing a lot of suction and patient is not reversing after surgery, that means your anesthetist is not good. You should change your anesthetist. He does not know how to give the laparoscopic anesthesia, and one day he will kill the patient and blame goes to you. Generally, anesthetists they never take their own blame. They say that madam must have used the more CO2, that is why the patient is not returning back. They immediately, and we generally if we do not know, we do not speak anything about that. So, mostly this is the anesthetist failure. This is second problem. Third problem, first problem is venous return, second problem is tidal volume decrease, third problem is hypercarbia. The CO2 is 200 times more absorbable than oxygen, and is 20 times more absorbable than room air. Carbon dioxide is a very fastly absorbed gas. So, it is getting 200 times more absorbable than oxygen, and it is good also. Do you know why? Because if it get absorbed so fast, air embolism will not develop. But the bad thing of CO2 is that this CO2 can cross the blood brain barrier and it can go to the our brain. Brain is very sensitive to the CO2, and if CO2 concentration of the brain increases, then it gives command to the cerebral artery to dilate, and there is a cerebral arterial dilatation. Once cerebral artery dilates, there is cerebral edema. Once the cerebral edema develops, then brain gives command to the heart that I am in trouble, I am in pressure. So, decrease the rate of the heart and there will be bradycardia. And if there is a bradycardia, then the cycle of the blood which is passing through the lung circuit will decrease. And if this lung per minute time which was circulating through the lung is decreased, the retention of the CO2 will be much more, because CO2 cannot be washed out with the lung, and there will be more hypercarbia, more cerebral edema, more bradycardia, again more hypercarbia, more cerebral edema, more bradycardia, and patient may die. That is why medico-legally it is important that every laparoscopic operation theatre should be equipped with the capnograph. If you do not have capnograph, you are in trouble. Suppose patient get dead in any operation theatre, and if a team for inspection of the medical council people are coming, first they see the anesthetist report that the CO2 level should be written every 15 minutes. ET CO2, that is called as end tidal CO2 concentration. And if E2 CO2 is more than 55 for more than half an hour, it is dangerous. Normally, our end tidal CO2 concentration, if someone will take, it will come below 20 normally. But suppose we do a lot of vigorous sexual activities or marathon exercises, at that time normal person also end tidal CO2 concentration go to 50. That is why if you are running very fast, you get some heat in your brain. You can feel that there is some warmth in your brain, blood circulation of the brain increases. Why? Because of cerebral arterial dilatation. But at the same time, because muscle is also taking power, everything, bradycardia does not happen. At that time, due to the sympathetic stimulation, there is tachycardia, and then CO2 is washed out, and then our ET CO2 level decreases. So, if during laparoscopy, if you see that CO2 level is increasing, what you should do? You should decrease the pressure of the pneumoperitoneum. If you are working on 15, bring to 12, and anesthetist what he will do? He will increase the rate of ventilation, so that all the CO2 which is accumulated into the blood should be washed out.
But I think it is vice versa. If the ET CO2 is low, not high.
If
low means that there is retention of air inside, not ET CO2 is high.
No, that is another. If you suppose there is a air embolism, then it goes immediately low and then high. So, this is another. Normally, if the CO2 is retention, then end tidal CO2 concentration has to increase.
Now, ET CO2, this means that the amount of carbon dioxide exceed, which will be picked up by the capnography over time.
Yes.
So, the amount of carbon dioxide coming or detected by this capnography is low. This means that's retained in the body.
No, that happens at end. Do you know what he is saying? That end tidal CO2 concentration sometime becomes very low. When it happens? When patient is gasping, when patient is ultimately dying. Do you know end tidal CO2 concentration how it is taken? It is taken by attaching one of the probe to the ET tube, endotracheal tube, and there is, I will show you in the operation theatre, it is attached into that. So, it is end tidal CO2 concentration, means when it is when the patient is expiring, at the end of expiration, what was the level of the CO2 in the tube. that is called as end-tidal CO2 concentration. So, if it is retaining in the blood, that happens at the end when patient respiratory is getting completely failed and patient is ultimately going to die. But normally when the patient is not dead, patient is not in the shock, patient BP is maintained, patient heart rate is maintained, then end-tidal CO2 will reflect the CO2 concentration which is retaining in the body. That is the reason CO2 is 200 times more absorbable. So, it is getting absorbed also faster and it is getting expelled also faster from the lung. Do you know we are ourselves a producer of CO2. During the marathon exercises, every human is making 200 ml CO2 per minute. We ourselves, CO2 is not a poisonous gas. CO2 does not support the life, but it does not kill the life. So, CO2 is not poisonous for us. We are also making each and every cell is making CO2 and every time we are expelling it out. So, end-tidal CO2 will give you the fair amount of the retention of the CO2. If CO2 is retained more, that does not mean it is always retained in the blood. Problem is not with the lung, problem is not that the perfusion is not happening, problem is that it is coming from the other sources into the blood. Now, the question is amount of absorption depends upon the pressure gradient. At 18 millimeter of mercury, absorption of the CO2 will be faster, because peritoneum is a semi permeable membrane and this side pressure is 18. So, there will be that is why we do the peritoneal dialysis to the patient. Peritoneal dialysis, when you are using, peritoneum is acting as a semi permeable membrane and it can diffuse the different toxins and the blood plasma from one side to another side. Exactly same way CO2 is getting absorbed by the entire peritoneal membrane and serous surface of the bowel and the surface of the solid organs. So, in the healthy patient it get out immediately, but if there is severe COPD or cardiac disease, then in those patients little increase in the hypercarbia can be dangerous and patient can be going to the acute respiratory attack and we can lose the patient.
But in COPD, there is some permissive hypercarbia is required.
Some?
So, does patient get benefit from the hypoxemia?
No, that is see hypoxia.
It's called permissive.
I will tell you, hypoxia and hypercarbia is different. We should never confuse hypoxia with the hypercarbia. Why I will tell you. Concentration of the CO2 and concentration of the oxygen is completely different thing. 100% oxygen saturation, even if it is there, then also hypercarbia will be dangerous, because oxygen is carried by the hemoglobin and oxygenation and deoxygenation is examined by our pulse oximeter by the color of the oxygenated and deoxygenated hemoglobin. Oxygenated hemoglobin is red, deoxygenated hemoglobin is blue, and that difference, but CO2 is not dependent upon the hemoglobin. So, CO2 is the only absorbed in the plasma. So, what you are saying that some amount of the CO2 is required for the patient which is hypercarbia, so that their hemoglobin will build up and they will have the stimulation on the respiration. That is the normal physiology. During surgery, it is out of the normal physiology, it is at the borderline left death and life. At that time, we do not require CO2 to stimulate, because patient is ventilated, patient is under artificial ventilation. We do not require patient to stimulate the ventilation. So, here the CO2 is dangerous and end-tidal CO2 concentration always we should measure, If you do the open surgery, you need only 5 parameter monitoring, that is ECG, pulse oximetry, plethysmograph, respiratory rate and pulse oximeter. But if you are doing the laparoscopy, 7 parameter monitor is must, capnograph and the temperature, these two are the additional required for the laparoscopy. So, that is why it is important. So, this is the third drawback. Third drawback is that it is 200 times more absorbable than the oxygen and 20 times more absorbable than room air. So, that is why CO2 can create hypercarbia, and that hypercarbia can create bradycardia, and that may be dangerous. Now, question is there any not other alternative? There are alternative. Many gases are there which can be used instead of CO2. One is helium, and some of the hospitals they are using the helium. It is expensive. Cerebral edema is also there in the helium also, but it is less than carbon dioxide. So, that is good. Another gas is nitrous oxide. Nitrous oxide is also very fastly absorbable gas. So, chances of air embolism is less and it can be used. It has less cerebral edema also, less chances of bradycardia also, but it has a problem, it is combustible gas. So, if you are doing nitrous oxide for diagnostic laparoscopy tubal patency test, it is good, but if you are doing for operative laparoscopy, you should prevent use of the electrosurgical generator. You can use other mode of energy like harmonic sometime you can use, but electrosurgical generator if you will use and if there is a spark, there may be chance of combustion. So, these alternative gases like helium, nitrous oxide, some people they use xenon, some people they use argon. If you will search the net, the xenon pneumoperitoneum, argon pneumoperitoneum, you will get many these type of gases which has been used by many centers, argon pneumoperitoneum and xenon all is used, but ultimately we have the better result with the CO2. So, these are the argon pneumoperitoneum, effective of pneumoperitoneum with the carbon dioxide over the argon. Argon has a problem that it is an ionizable gas. So, if you are using the electron, it can transfer the electron from the tissue to the electrode, it can act as a bridge, but some people they are happy they are using argon, but it does not have benefit over the CO2. Then xenon is also used by many of the people, xenon pneumoperitoneum. So, these are also pneumoperitoneum. So, it is a deficiency of the comparison of the carbon dioxide and air and with the xenon. This is room air and xenon, and then nitrous is already reported, and that is good. Nitrous is good if you are doing for, this is nitrous you can use if you are using for diagnostic laparoscopy. So, these all has been tested and all has some drawback, some advantage, some disadvantage. So, ultimately CO2 is safe and CO2 you can use, but it can create hypercarbia, for that you should be careful. Now, the fourth drawback of the air embolism is air embolism itself. Fourth drawback of pneumoperitoneum is air embolism. CO2 is safe only up to 2 liter per minute. In Hopkins, what they did, that they injected the different gas intravenously into a large animal. When they injected the oxygen, 20 ml oxygen per minute, animal was dead. When we injected the room air, 200 ml air can be tolerated. After that, there will be air embolism. And when they injected the carbon dioxide, up to 2 liter of the carbon dioxide, if you will inject in the vein, then also patient will not die. 2 liter. Why? By the time it reaches to the heart, it is absorbed and it is disintegrated. That is why with the Veress needle, we set the rate of flow is 1 liter. So that accidentally if our Veress needle is any of the vein, that also will not create any problem, is not it? So, that is why Veress needle is used as one of the important point, and it should be taken very carefully, we should use. So, this is important. Now, what I was talking about the different gases and fourth. Now, how the air embolism kill our patient, that I wanted to show you. Air embolism has a problem that if you are using it, it will show you the different route of entry. Like suppose this is heart and here is a right atrium, this is right ventricle, this is left atrium and here is the this is the inferior vena cava. And now this air bubble is coming, here is the air bubble which is coming. Why air bubble coming? Why air bubble coming? Air bubble comes due to two reasons. One reason is that our venous needle has directly pricked any vein and we are directly putting the gas into the vena cava at a rate of more than 2 liter per minute. And another possibility is that we are dissecting at high pressure 18 millimeter of mercury pressure and we are doing cholecystectomy, we are separating the gallbladder from the liver, or you are doing myomectomy, you are separating the myoma, or you are doing lymphadenectomy, you are separating the lymph node of iliac vessel and any venous sinuses are open. And this open vein will start taking the CO2 just like intravenous. Remember, we should never confuse the air embolism with the hypercarbia. Hypercarbia develops due to absorption of the CO2 and air embolism develops due to the entry of the CO2 directly into the vein. When there is a air embolism, your end tidal CO2 concentration will be normal. It will not show you anything, it will be normal, but suddenly patient may die. How? This bubble will come to the right atrium, then it will come to the right ventricle, and suppose there is a VSD, this patient has a ventricular septal defect, there is a hole into the lung, there is a VSD, and now this bubble has entered from the right atrium to the left ventricle, and from the left ventricle it will go to the LAD, left anterior descending artery. We know that there are different arteries here, coronary artery, and it will go to the left anterior descending artery and it will block the artery, and theoretically this air embolism will kill our patient also. There will be ventricular fibrillation and death, and patient may be killed in the table. So, the patient who has severe COPD and severe ventricular septal defect or atrial septal defect, we should avoid doing laparoscopy. If you are doing laparoscopy, then better to do gasless laparoscopic surgery, because this CO2 may be dangerous. Now, the question is what to do in the normal patient. This is an abnormal case which I have described. The patient has the ASD and VSD, but what to do the normal patient? Normal patient does not have the same physiology. In normal patient, what happens that from here there will be a pulmonary artery, and from pulmonary artery the blood will go to the lung, isn't it? And from the lung it will create the pulmonary infarction. So, this blood from here and bubble from here will go to the lung, and there will be pulmonary embolism. Now, how to know and how to avoid it? To know this, what you should do, that if suppose you are doing surgery and suddenly patient is collapsed, patient does not have pulse, patient is completely collapsed, then immediately your anesthetist or you should put a sphygmomanometer into the auscultatory area. This auscultatory area is the right second subcostal area, and you will hear a very peculiar murmur that is called as water wheel murmur. This water wheel murmur is one of the very important and definitive sign of the air embolism. What is this murmur? When you take the shower in your bathroom and suppose water supply is going to finish, there is no more water in your tank, it is the last part of the water is coming. You might have heard a peculiar sound, that is sound coming. Why this sound is coming? Because water is coming mixed with the air, and that gives you peculiar sound, because water is thick, air is thin. So, thick and thin viscosity when passed from the tape, it gives you water wheel murmur. Now, to prevent this problem, you have to fill up the tank again with the water. Exactly same way, this is the valve, this is the pulmonary valve here, and here is the pulmonary valve, and blood and water is going mixed here. This is blood, this is blood, this is blood, and in between blood there is air. This is air, this is air, this is air bubble, and air bubble with the blood, air bubble, blood. So, once it crosses from the pulmonary valve, it creates a fluttering of the sound. In some of the book it is written mill wheel murmur, just like a wheel running in the mill, or water wheel murmur, like a wheel running on the water. So, patient during surgery is completely suddenly collapsed, and you do not have any idea, because you were doing surgery fine, you know that you are not bleeding because everything was going fine, then only probable cause is the embolism. And to prevent embolism, what your anesthetist will do? Immediately he will put a swan gauge catheter. This swan gauge catheter can be put from the jugular vein, and directly this catheter will go to the right atrium, and a frothy blood will come out, and your part what you have to do? Immediately stop the surgery, remove all the instrument, switch off the insufflator, deflate the abdomen, and turn the patient towards the left and head down. Once you will turn the patient towards the left, all the air bubble which was going to the left side of the heart, it will come to the right. Why? Bubble wants to go up, and once you will turn the patient head down, the blood which was going to the heart will remain to the vena cava, because vena cava is above and heart is down. You are putting the patient's head down. So, you are deviating the bubble going towards the heart and lung, and already you have switched off the insufflator, and now the fresh blood will come, which will just start dissolving those bubbles, and the patient will survive, and patient pulse will return, patient will be okay, BP pulse, everything will come. If you immediately diagnose and you do immediately corrective measure, but if you could not diagnose it, then it is too late, there may be big pulmonary embolism and infarction. If patient is young, a small pulmonary embolism they can tolerate. Incidence of pulmonary embolism in laparoscopy is 1:1000, and the death rate is 1:10,000. Incidence of pulmonary embolism is 1:1000. In 1000, one patient get embolism in laparoscopy, but death is rare, it is 1:10,000, and most of the people who die, they have already comorbidities, already previous comorbidities, and then death happens. In some of the book it is written that this reported death 1:10,000 is under reported. Why they say? It is institutional data, it does not include the death in the private sector, because in private sector if something like this happen, we put the patient in the ICU, we keep the patient on the ventilator, and then all the clinical side is masked. So, exact cause of the death air embolism can only be found if the patient will go for postmortem or the good investigation. Otherwise, we write the cardiorespiratory failure and patient death. So, that is why some of the people they say it is underreported, it is not, the incidence is much more, and this incidence why happens? Because we are using venous needle. So, these are the 4 major drawback of the CO2 which we are using, that is the decrease in venous return, decrease in the tidal volume, hypercarbia and air embolism. That is why the patient who is severe COPD and cardiac disease, we should not do laparoscopy. So, we were discussing about the contraindications of the minimal access surgery. In that context, we have seen that the severe COPD and cardiac diseases, that these patients are not good, but these are relative contraindication. Relative contraindication means, suppose a patient of simple bronchial asthma with the mild bronchial asthma comes to you, then you should not refuse it, because in those patients the laparoscopy may be useful, because intraoperative you have to be little careful, but post operative outcome will be very good, because patient can be discharged same day. So, this severe word you should always keep in mind. Any COPD or cardiac disease is not a contraindication. Severe COPD and cardiac disease is a contraindication. And why it is, already we have discussed that decrease in venous return, decrease in tidal volume, hypercarbia and air embolism are the problem. Another is grade 2 or grade 3 shock. Laparoscopy can be performed in grade 1 shock. Suppose patient has rupture ectopic pregnancy and patient comes within first few hours. You can do very easily laparoscopy. You can put the telescope, you can suck all the blood and you can perform the ectopic, but patient came after 3 days and already there is a 2 liter of the blood inside the abdomen. When patient has a severe tachycardia, patient does not come walking, patient come on the stretcher. Now, in those problem is that if you will put the gas inside the abdomen and patient was compensating, it was a grade 2 shock, if you will put the gas in the abdomen, then further decrease in the venous return will create the irreversible shock and then you can lose the patient. So, those patients are not good. In those patients you should avoid severe COPD, cardiac disease, grade 2 or grade 3 shock. Second contraindication is generalized peritonitis. Laparoscopy is good for localized peritonitis. You have done surgery, there was duodenal perforation and patient came within first 12 hours, you do the no problem, peritonitis is localized, there was rupture appendix, you can do the surgery within first few hours, but patient came after 72 hours where the cardboard like rigidity is there and it is a generalized peritonitis, then laparoscopy is not recommended. Now, question is why it is not recommended? Due to the 5 problem. First problem of generalized peritonitis is that cardboard rigidity which is caused due to the generalized peritonitis cannot be removed by giving a excess amount of muscle relaxant, because it is not due to the muscular tone, it is due to the toxins which is absorbed by the muscle through the peritoneum. So, that cannot be removed by the muscle relaxant, and if the cardboard rigidity in the abdomen is there, if you will try to put the trocar and cannula, you can perforate the bowel. Second problem is vision is very bad. In generalized peritonitis, the problem is that reflecting power of the peritoneum is lost. Do you know, sometime when we go to the studio to take our photograph, in the studio they keep the white screen in front of you like umbrella, or if you see the movie shooting, they have a big white screen they keep in front of the models or the actors. What is the function of those screen? That light once comes on our face, it reflects back and again those reflectors will again bring the light on the face. So, that there will be no shadow, there will be homogeneous distribution of the light and that will make your beautiful image, beautiful picture. Exactly same way in the abdominal cavity, the distended dome of the peritoneum, act as just like a reflector, and once our light goes to the gallbladder or uterus, that light reflect back to the peritoneum and peritoneum will again reflect it back over the tissue. So, there is a homogeneous good image without much shadow and a good distribution of the light will make a beautiful image. But in generalized peritonitis, this red color has a bad property of absorbing the light, because it is no more shiny. This is the peritonitis here, and in the peritonitis due to this inflammation, the reflection of the light is bad, that is why image is bad, image is not good. These all are the inflamed peritoneum which is absorbing the light. So, the quality of the image is not good. Third problem is more chances of hypercarbia. Inflamed peritoneum can absorb the CO2 4 times faster than the normal healthy peritoneum, because it is hyperemic and breached. So, direct CO2 absorption will be fast in the inflamed peritoneum, and sometimes chances of bacteremia and septicemia, because the bacteria which is touching on the inflamed peritoneum, due to the CO2 pressure it can be taken by the blood faster, and then there is increased chances of septicemia and hypercarbia, and that also is a problem. Next problem is fibrinous exudates. We know in the generalized peritonitis white curd like exudates are distributed all over the bowel, and those fibrinous exudates can make a interbowel loop adhesion, and there is a pus pocket created in between the intestine loop, and if you will try to separate it by the laparoscopic instrument, there may be chances of the increased chances of the injury of the bowel. So, due to these reasons generalized peritonitis is a contraindication of laparoscopy. So, the best time of laparoscopy after the duodenal perforation is maximum up to 48 hours. After 48 hours, if the peritonitis becomes generalized, then you should avoid doing laparoscopy. Next contraindication is previous extensive abdominal surgery. Laparoscopy can be performed if there is a 1 or 2 surgery, like one cesarean section was performed, one myomectomy was done, it is okay, or cholecystectomy was done. But this type of surgery where previous extensive surgery and bad scar and multiple operation is performed, now there is no room inside the abdominal cavity to create pneumoperitoneum. There is no space, even the Palmer's point is here also destroyed. So, there is no space you can put the varus needle, and those cases you should avoid doing laparoscopy. Then comes previous generalized inflammatory disease or irradiation. Like suppose patient has received the irradiation due to any reason, patient was having cervical cancer, prostate cancer or cancer of the bladder, urinary bladder, or due to any reason he has received the radiation on the abdominal wall. Once the patient abdomen received the abdominal wall radiation, then all the layers of the abdominal wall fuse together. There are no more separate, rectus and muscle and the peritoneum is not separate. In those situations, putting the varus needle is very risky, it can immediately perforate the bowel. Again, generalized inflammatory diseases like miliary tuberculosis, Hodgkin's lymphoma, non-Hodgkin's lymphoma, Crohn's disease, ulcerative colitis. In all those generalized inflammatory disease, there is a chances of the increased bowel perforation. So, laparoscopy is a relative contraindication. Again, I am telling you, it is not an absolute contraindication, depending upon the severity that you have to decide. Now, the next is hyper and hypocoagulable state. If the patient has polycythemia vera, then laparoscopy should be avoided, because in hypercoagulable state, little decrease in the venous return can immediately develop the DVT, and those patients are very prone to developing the pulmonary infarction. Just like the renal transplant, the patient who get renal transplant, they have more amount of erythropoietin secreted, and sometimes their hemoglobin level increases to 22 hemoglobin goes. So, those are hypercoagulable state, and suppose those patient comes to you for laparoscopy, and without correcting the hypercoagulable state, if you will do it, your patient will get DVT. Why? Open surgery also patient can get DVT, but here because of the venous return is decreased, more chances are there compared to open. So, laparoscopy is contraindicated. First you should correct it and then you do. Again, hypocoagulable state. Nowadays, if the patient has any cardiac history, the physicians they immediately prescribe the coumarins or aspirin for antiplatelet. Now, the problem is platelet aggregation is compromised, and laparoscopy is contraindicated in the patient who has the compromised platelet aggregation, because during surgery it will not bleed, because CO2 pressure will stop the capillary bleeding. But once you have removed your trocar, you back home, you are sleeping at night, you will get a call that patient BP is low and patient abdomen is distending. Why? It restarted bleeding once the pneumoperitoneum is removed. So, you should must get the INR done for the patient who is taking aspirin and or coumarins. International normalized ratio, that is prothrombin time, should not be more than 2. If INR is more than 2, then you should stop the aspirin, coumarins, get a cardiac clearance, and after the coagulation profile is returned to the normal, prothrombin time is normal, then we should do laparoscopy after 1 week. So, first you should stop all those antiplatelet for 1 week and then you call the patient for surgery. So, these both are contraindication, hypercoagulable as well as hypocoagulable.
So, INR 2 can do
Which one? INR less than 2 you can do. less than 2 you can do or up to 2 you can do, more than 2 is a contraindication. Now, next contraindication is advanced stage of pregnancy. Laparoscopy is contraindicated after 20 week of pregnancy. Up to 20 week of pregnancy, laparoscopy is good, better than open. Like suppose patient is pregnant and patient has ovarian torsion, then you can do laparoscopy and outcome is better, spontaneous abortion is less. In the older time there was a myth that CO2 will create problem with the baby fetus, but it has been proved that fetal hemoglobin is much tolerating better CO2 rather than the adult hemoglobin. So, fetal hemoglobin does not have any problem and they are more smart. The babies can tolerate the CO2 better than the mother. So, that is why pregnancy is not a contraindication. Lapro is safe in pregnancy, but only up to 20 week. After 20 week, it is a relative contraindication, because there is no space in the abdomen and there is a guttering effect. Paracolic gutters are pressed onto the flanks. So, if you want to see the ovary, it will be difficult to find it out, because due to gravid uterus it is pushed into the pelvis and you may have not that much space to put your trocar and move the instrument. But there is a controversy. Controversy is that there is a controversy in between the SAGES guideline and WALS guideline. If you will search the SAGES guideline, then SAGES guideline this okay, it will be all right. Guideline for pregnancy. So,
What is the incidence of the fetal?
this is the SAGES guideline of pregnancy and it is very important. According to the SAGES guideline, the laparoscopy is safe in any trimester of. They recommend even up to the last trimester also laparoscopy can be done. But according to the SAGES, Society of American Gastrointestinal and Endoscopic Surgeon. So, this is guideline for diagnosis, treatment and use of laparoscopy for surgical problem during pregnancy. And according to the SAGES guideline, if you will see, then it says that here preoperative laparoscopy and trimester of pregnancy, and according to the SAGES guideline, laparoscopy is safe performed during any trimester of pregnancy. So, they recommend that even up to last week, but they also say that 26th to 28th week is better and after 40 week you have to be careful, but outcome can be equal and you can do in any trimester. So, this is a strong and moderate guideline which we should keep in mind, but according to WALS guideline, advanced stage of pregnancy is a relative contraindication. Now, suspected carcinoma, yes.
What about the first trimester?
You know, in the first trimester we should try to avoid the laparoscopy just like open surgery, but if it is emergency which cannot be avoided like acute appendicitis which is impending perforation or severe ovarian torsion which is creating a big problem and increasing pain, then if you have to compare laparoscopy versus open, laparoscopy is better. Laparoscopy is better compared to open. Spontaneous abortion is less in laparoscopy compared to open surgery. So, in any pregnancy, if we can avoid, better to avoid the surgery, but if it is essential, then laparoscopy is better than the open. Now, suspected carcinoma, yes.
So, for a new beginner surgeon in lab, open will be better or lab will be better in first trimester in case of say?
You know that is a very good question. I will tell you that wherever you have the suspicion and if your learning curve is one of the limitation, we should avoid doing laparoscopy. Do you know there is a grading system, grade 1, grade 2, grade 3, grade 4. In that grading system of the skill of the surgeon and the level of the surgery what you are doing, in that grading I will discuss later in the latter part of the course, that to whom not to operate is very important. If you have not done enough appendicectomy in a normal patient, then you should never select a patient who is already pregnant. and suppose it is pregnant of 30 week of pregnancy or 20 week of pregnancy, also it is better to avoid during learning curve. Do you know why? It is not only the experience, the problem is the ability to tackle the complication comes with the little experience. So, for the beginners I will not suggest to take those cases for the surgery, but of course, if you have any experienced surgeon together, then you can do. So, learning curve should be respected, that is important, because if you will do 10 good surgery, successful surgery, you will build up a lot of confidence, but if you will do one big complication, you will lose all the confidence suddenly. So, that is why our confidence takes time to be built up, and that in those period it is better not to do the stunt, just like if you are driving a car and you have just started learning few days ago, then you should not do the stunt, otherwise more likely the accident can happen. So, suspected carcinoma is also one of the contraindication. Remember, known case of carcinoma is not a contraindication of laparoscopy. If already you know that patient has cervical cancer, you can do radical hysterectomy. If already you know that patient has a mucinous cyst adenoma of the ovary with the metastatic type 2, then you can do the complete oophorectomy. You can use a type C good quality of endo bag. You can put entire ovary into the endo bag and you can take it out, or you can do hand assisted laparoscopic surgery, and without losing the integrity of the tissue, you can do the en bloc dissection. But suppose you have not done the work properly and there is a suspicion of the carcinoma, and those suspected carcinoma will be a big problem. Just 9 months ago, one cardiologist from the United States of America, his wife underwent supracervical hysterectomy, and after supracervical hysterectomy, she developed metastasis because it was a sarcoma. And then that cardiologist has filed a case and complained in the FDA, and you will be surprised, FDA has stopped the use of the morcellator for the supracervical hysterectomy all over USA, and Ethicon company has to withdraw the morcellator now from all the hospital of the United States of America. So, I am just giving you, if you will put FDA, this is FDA and morcellator, then you will get this type of a lot of laparoscopic uterine power morcellator. FDA once again using laparoscopic power morcellator. Laparoscopic uterine power morcellator in hysterectomy, FDA issued a update safety communication. This is November 24th, 2014. It is not a very old story. And morcellator, power morcellator, they have, and if you will put Ethicon after FDA, morcellator and Ethicon, then Ethicon is one of the world leader of manufacturer of the morcellator, and see power morcellator recalled as evidence of the uterine, and FDA say can spread cancerous tissue. Can you see that? So, there was one incidence, and it is a big problem now in the United States of America, that they are against the morcellator, and it is about to get stopped use of the morcellator in laparoscopy. And you can understand that if the morcellator use will be completely stopped, then what will happen? How can we do the myomectomy? We cannot do the myomectomy, big myoma cannot be removed, we cannot do the supracervical hysterectomy. So, do you know why it happens? Because of this problem, J&J suspend power morcellator sale, they have stopped selling it also in India, and they are recalling the power morcellator from our every advice against morcellator used in hysterectomy. Do you know in myomectomy still they have not given the verdict to not use, but supracervical hysterectomy. So, what it proves? It proves that suspected carcinoma is a contraindication. That means, if patient has a suspicion of the cancer, suppose patient has a ovarian tumor, CA 125 is borderline, LHS, FSH, estradiol is not confirmatory, there is no any ultrasound report which is against or which is in the favor, and you are in suspicion, then do not do ovarian cystectomy, better to do the complete oophorectomy or you do the open surgery, because metastasis and even the port site metastasis is considered as a negligence by the surgeon. If you already know that cancer is there, then you are allowed to do laparoscopy, because patient will get the consent that yes, I know that cancer is there, and I know that it may not be 100% cured, and I know the prognosis and everything is explained to me, and surgeon is also aware. So, he will use a good quality morcellator, he will use a good quality endo bag, and he will use a hand port to remove it. That is why suspected carcinoma is a contraindication. Now, there are few specific indication of laparoscopy. In these cases only laparoscopy should be done, nothing else. These specific indications are cirrhosis of liver, sickle cell, HIV and ectodermal dysplasia. Cirrhosis of liver, once upon a time it was thought that in cirrhotic patient laparoscopy is not good. Why? Because cirrhosis can create a problem for the patient, but now it is proved that cirrhosis patient laparoscopy is a method of choice. If you will put cirrhosis, this keyword, and laparoscopy, these two keywords, then you will see that laparoscopy should be performed. Do you know why? Because cirrhosis is not a contraindication in the laparoscopic patient. The role of laparoscopy in diagnosis of laparoscopic cholecystectomy and liver cirrhosis. If you see this literature, they say, and the conclusion is laparoscopic cholecystectomy is effective and safe procedure and should be treated as a choice of the systematic cholecystectomy in a patient who is having considered as cirrhotic. Do you know why? Cirrhotic patient, if it is surgery is required and if you do the laparotomy, patient cannot tolerate the trauma, because their enzymes are bad, their protein synthesis is bad. They may die due to the burst abdomen, they may die due to the wound descent. So, for those patients laparoscopy is a specific indication. Laparoscopy should be considered first. Only thing is problem with the cirrhosis is that clotting factors are not good and there may be coagulation profile should be bad. So, that is why vitamin K should be administered properly, and if any coagulation profile is required, you should administer it, you should infuse the coagulation profile. Better to avoid surgery, do not do surgery, but if surgery is unavoidable, then laparoscopy is better than open. Next, a specific indication for laparoscopy is sickle cell disease. Once upon a time it was thought that sickle cell is bad for laparoscopy, because sickling crisis will be more, but now it is proved that laparoscopy sickle cell is better. So, laparoscopic cholecystectomy in a sickle cell disease. Let us see what this article say. It is say that for sickling patients laparoscopy the mean operating time is better, laparoscopic cholecystectomy resulted in shorter hospital stay, fewer postoperative complication and then the open, and patient of sickle cell disease may be procedure of choice. Again it is coming procedure of choice. Procedure of choice for the treatment of cholelithiasis in such patient, not only gallbladder, even other surgery. Sickle cell laparoscopy is better. You should not do open surgery in the sickle cell patients, and laparoscopy can be tolerated better than. Then comes HIV. For HIV patient laparoscopy is gold standard. Do you know why? If you will do open, you are also in trouble, because you are handling the tissue. In laparoscopy interior milieu is maintained, you are outside. So, I am safe. Another problem, patient will be discharged same day, there is no chances of infection to the other patient. Another problem, there is no need of any dressing, no need of any spreading the fomite, spreading the tissue here and there. Another problem, that your nurses are also safe and patient immunity will not be further suppressed. Patient immunity whatever is there, it will be maintained. If you will do laparotomy in a AIDS patient, they will not die due to the pathology, they will die due to the infection of your wound, isn't it? So, laparoscopy is gold standard for HIV patient. There was only one concern, that is it safe to use reusable instrument, and it is safe. WHO has given the clean sheet that glutaraldehyde which we use to sterilize the instrument is very good virucidal, and HIV patient cannot survive in the glutaraldehyde environment. So, if you will do the proper disinfection by the glutaraldehyde, then HIV virus will not create the transmission from one patient to another. Then ectodermal dysplasia is an autosomal recessive condition in which there is less sweat gland and hair follicle in the patient. So, those patients if they will get the surgery, and those patients if you will perform the procedure and it is open, then due to sympathetic stimulation they get the hyperthermia, and due to that hyperthermia patient has a problem, and those problems can be dangerous, because those hyperthermia patient may die immediately. But if you will do laparoscopy, then this problem can be solved and patient will not get hyperthermia. So, these two problems can be taken, and you should avoid doing open surgery for those patients. So, ectodermal dysplasia is best for the laparoscopy. So, if we will see risk versus benefit, risk is more, benefit is less. Risk is more, benefit is less. It is a risky surgery. I am not telling mortality rate, I am not telling morbidity rate. Risk is more and benefit is less. If you want to make the benefit more, just like, do you know what is the most common cause of death? Unnatural death, accident, and most common accident is road traffic accident. So, risk is more. If you are traveling on a car or aeroplane or train, you have a risk that you will be killed one day, but in spite of that risk you are taking that risk, because quality of life will not be good if you will not take this risk. Exactly same way laparoscopy is risky surgery, but patients are ready to take this risk because the people who survive their quality of life is good. But if you want to minimize that risk, there are some internal control objectives. If you will use the control environment, proper risk assessment, proper control activity, proper monitoring and information and communication. If these are few of the objectives which you will keep in mind, that is proper evaluation as a team, anesthetist, you, and you should try to examine the patient and decide whom not to operate, because you have to enter into the abdomen at your own risk. You cannot tell later suppose something happens, you cannot tell the medical council or the court that patient was having COPD, that is why he died, and you cannot say patient was having hypercoagulation effect, that is why it is died, because nowadays the lawyers are doctors actually. Most of the medical legal cases in India which is handled are not only lawyers, they are doctors also. So, they know that how to select the patient in laparoscopy, and if they will prove with the literature that this is a contraindication, relative contraindication, now we are in trouble. So, we must select the patient. The success of a good laparoscopic surgery is paramount is a good patient selection, and after that your surgery will be better. So, this was regarding the advantage, disadvantage, indication and the contraindications for the minimal access surgery. So, thank you very much.